Welcome to This Explainer, where we are tackling the high-stakes world of evaluation and management coding. Look, whether you're a provider documenting patient care or a coder making sure everything's compliant, getting EM coding right is absolutely crucial. We're talking about the literal lifeblood of your practice's revenue and your frontline defense against those crippling audits. So today, we're going to break down the complexities of medical decision-making, untangle the messy rules around modifiers, and build a fortress around your claims. So, let's kick things off with a critical question every single practice has to face. Are incomplete E&M charts risking your revenue? The harsh reality is, if your documentation is vague or missing pieces, you are walking straight into a trap of downcoding, outright claim denials, and intense scrutiny from the OIG and CMS. Accurate documentation isn't just about getting paid. It's about clinical continuity, your legal protection, and staying financially compliant. Simply put, if your charts aren't telling the full story, your revenue is for sure at risk. Here's our roadmap for today. We'll quickly cover the EM coding evolution, then mastering medical decision-making, proving medical necessity, modifier rules and pitfalls, and finally, audit risks and denials. Let's jump into Section 1, the EM coding evolution. It's crazy to think about how much this has changed. Remember the old pre-2021 rules where you had to count every single little bullet point in the history and physical exam just to justify your code? Yeah, that usually just led to bloated, copy-pasted notes and severe carpal tunnel. Thankfully, the new rules stripped all that away. Now, your level is based entirely on the complexity of your medical decision-making, or MDM, or the total time spent on the date of the encounter. It's a much more streamlined approach that puts the focus squarely back on actual patient care. Now, these official AMA guidelines apply really broadly across different categories, like office visits, hospital inpatient care, and consultations. They give us a standardized framework for selecting service levels. But you've got to remember, while the AMA sets these codes, the true purpose of your documentation is to support the current and future care of that patient. The guidelines just give us a common language to translate that care into a billable format. Moving right along to Section 2, Mastering Medical Decision-Making. So how do we actually measure this? To determine your MDM, you have to look at three distinct elements: the complexity of problems addressed, the amount of data reviewed, and the risk of complications. The golden rule here is that at least two of these three elements must meet or exceed a specific level to qualify for that final MDM level. So if you've got a moderate problem, extensive data, and moderate risk, two of those hit the moderate threshold, making your final MDM level moderate. Makes sense, right? Let's apply this to a real-world scenario. Imagine a patient comes in with worsening shortness of breath. They're having a COPD exacerbation, their pulse ox is sitting at 89%, so you order a chest x-ray and give them a steroid injection. How exactly do we level this visit? This lands solidly at an established patient code 99214. Why? Well, you're managing a chronic illness with an exacerbation, which counts as a moderate problem. You ordered a test, and you gave a prescription-level intervention with that steroid injection, which gives us moderate risk. So 2 out of your 3 MDM elements are moderate, firmly landing this encounter at a 9924. All right, let's dive into Section 3, Proving Medical Necessity. Assigning an MDM level is great, but it means absolutely nothing if you can't prove medical necessity. It's basically a procedural logic check to ensure what you found justifies what you did. First, you review the clinical documentation, the chief complaint, HPI, the plan. Second, you pick the most specific ICD-10 diagnosis code you can find, completely avoiding those vague, unspecified codes if possible. Third, you've got to directly link that diagnosis code to the CPT code. And finally, validate it all against payer-specific coverage determinations. Take a look at how this linkage works in practice. In the hypertension scenario, a stable patient just popping in for a med refill easily links to a low-complexity 99213. But compare that to the diabetes scenario. The provider is managing a foot ulcer, aggressively adjusting insulin, and reviewing labs. That high-risk, active management perfectly justifies a high-complexity 99215 code. The documentation notes clearly show the medical necessity for all that time and cognitive load. Now, you have to watch out for these specific documentation red flags. Cloned notes, where the exact same block of text is copy-pasted across multiple visits, are an immediate trigger for total claim denials. Unless your patient is literally a clone, their notes shouldn't be. Also, just dropping all systems negative without clinical context or pasting outdated lab results, massive audit risks. Your notes must be totally individualized and tell the unique story of that patient's visit on that specific day. Let's shift gears to Section 4, Modifier Rules and Pitfalls. Modifier 25.
We all use it, and auditors love to scrutinize it. It is strictly for a significant, separately identifiable E&M service. This means your evaluation went way above and beyond the usual pre- and postoperative care for a procedure done on that same day. You absolutely must have distinct documentation proving this E&M service stands on its own 2 feet.
So for example, let's say an established patient comes in for a routine hypertension follow-up. But during the visit, you also evaluate and do a wart removal procedure, that's CPT code 11055, on the exact same day. How do we code this so the payer doesn't just bundle the visit into the procedure and deny it?
You've got to apply modifier 25 directly to the EM code, which is 99213 here. So your claim shows 99213-25 right alongside the procedure code 11055. This modifier is basically shouting to the payer, hey, yes, I did a minor procedure, but I also managed their hypertension, which took a completely separate and significant amount of work. But here's where people mess up. The most common error is literally just adding the modifier to the wrong code, like sticking it on the wart removal instead of the EM visit. Another huge red flag is modifier stacking without any justification, or leaning too hard on modifier 59 when you really should be using more specific modifiers. Always, always make sure your audit trail clearly separates the procedure note from the EM note. Which brings us to our final section, Section 5, Audit Risks and Denials. Let's talk about the OIG's favorite words, fraud, waste, and abuse. There's strict legal differences here. Fraud is intentional deception, like billing for a visit that never even happened. Waste is ordering follow-ups or tests that just don't have a medical benefit. Abuse is a bit trickier. It's inconsistent with good practices, like slapping a modifier 25 on every single claim just to bypass payer edits. Do not do that. It's a massive compliance red flag. So how do you fight back? You need to run a root cause analysis on your common denial codes. Take a code like CO50, which basically means not medically necessary. When that pops up, your analysis needs to pinpoint exactly what went wrong. Did the documentation fail to justify the level of care, or did someone just forget to link the ICD-10 to the CPT? Finding that root cause is the only way to plug those revenue leaks for good. And this is where things get really cool. We can now use AI and computer-assisted coding tools to proactively scrub claims before they even go out. These systems read clinical documentation in real time, suggest the right codes, and validate them against national logic edits. It acts like an automated compliance validator, instantly catching missing medical necessity links or conflicting modifiers before they ever trigger a costly audit. It's a total game changer. So as we wrap up this explainer, I want you to ask yourself a tough question. If an auditor walked into your practice today and pulled 10 random charts, would your revenue survive? Make sure your providers are telling the complete clinical story and your coders are translating it perfectly. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.